not, unfortunately, because. All right, I'm just going to get started here. I'm Jillian Grafton, for those that don't know me, and I am visiting you from the cardiology side of things, and we'll talk a little bit about mechanical circulatory devices. And then you're going to have to see the old Henry Ford template yet one more time. So I don't have any disclosures. So we're going to talk a little bit about the available percutaneous devices, indications and contraindications, and some of the complications. But first, I want you guys to tell me a little bit about cardiogenic shock. I feel like we talk about this all the time, but when we're talking about cardiogenic shock and thinking about, is this a patient that we should be calling cardiology for devices, what are some things that make you trigger saying, okay, we should make that call? You guys all can treat cardiogenic shock, and you're going to do it almost every day in your day-to-day life. It's just the fact of care that we provide. So I guess first, the definition of cardiogenic shock. Oh, could be both. So what are some numbers? Yeah, in real life, there's not really numbers because it's really perfusion, but on like definitions of trials, there are numbers. Yeah, sometimes the elevated lactate. What is it? Yeah, and some will use 2.2, some will use less than 2 on support on inotropes, and less than 1.8. Yes? There's a blood pressure one. They use like systolic blood pressure less than 90 for 15 minutes, or requiring. We have a patient that does meet that criteria, and so we talk a little bit about perfusion. So what are some ways that we look for adequate perfusion? Just can't hear anything. Okay, hear an output. Yep. Yep. Heart failure handshake, right? Put your hands on the legs. What else? Yeah. Not a peripheral. Good job, please. Central, or close to central. And then we all can quickly calculate a FIC cardiac output, right? How do we do that? What is that height weight? What are you trying to calculate there? Yeah, but what's it going into? Yeah, for FIC cardiac output, right? So oxygen consumption's on the top of that equation. So we can use MedCalc and like put in all these types of numbers. Really, the best one that you could probably use, and that has been shown to correlate the best is the Damer equation, which is actually 125 times the BSA. So it's pretty easy, and you can just do it. You don't need to find the med-calc and find out what the heart rate is and the weight at this minute. So 125 times BSA. That's oxygen consumption, and then that's divided by A minus V times 10 and 1.34. It doesn't always have to go to the computer and put in all these. You can do it on your paper. And so what is the SpO2, what typically do you use as, okay, that is good enough? Or, you know, it should be good enough. 70 for the sepsis, yeah. It kind of depends. Like the chronic people that are anemic, stats in the 50s can even give you index of greater than 2.2. So that's why it's good to have kind of a number in your head about looking what the SpO2 is and looking at the hemoglobin, and you can get a little bit of an idea of what their cardiac output is. But you can calculate it quite quickly in using the equation. And then how do you get from cardiac output to cardiac index? By body surface area. Any other questions? Because I think the big thing is taking those numbers. It's good to know those numbers. The physical exam and the clinical test or evaluation is also extremely important, because some of our heart failure patients are walking around with a cardiac index of 1.5, and they're actually doing okay. Their long-term prognosis is not excellent, but it wouldn't be a reason to necessarily bring in even inotropes or mechanical support. So I just want to quickly talk about inotropes because they seem pretty easy and pretty straightforward, but just kind of make sure that we're all on the same page about inotropes. So when are they best used? Not a hard question, just. So cardiogenic shock patient, right? What would you grab for and when? Milrinone versus dobutamine. Is there one med you would go to rather than the other, and are there certain circumstances you would choose one or the other? Yeah, so if you have renal failure or pretty significant CKD, just think of yourself using double the dose. So if you're on 0.5 of milrinone and you have really bad renal function, you're on like massive amounts. And yeah, I'm a little like biased towards milrinone. I'll be upfront about that. I think it just works better because of the increased pulmonary vasodilation. But and the trials don't necessarily show that you get much more arrhythmias, but I do think you get more tachycardia with the dobutamine.
We're still on the objectives and talking.
Any other questions about milrinone versus dobutamine? Milrinone, you'll get a little bit more hypotension. So that would be a reason to not use inotropes. Sometimes you'll get away with dobutamine a little more, but still, if you have to use vasopressors, you have to use vasopressors. So, and the kidney issues is a little bit hard because if it's AKI because of cardiogenic shock and malperfusion, then inotropes will turn that around really quickly. RV failure, milrinone is actually would be a go-to choice as long as they're not too hypotensive. The milrinone does work well for RV failure. So I think the biggest thing is usually if they have borderline blood pressures and their kidney function is a little bit up, is trying an inotrope. But if they're getting hypotensive, the you should not increase the dose more. But, and I say that, but you see it a lot. Like, they were hypotensive, so I turned it up more, but really it should be going to vasopressor. Questions? So butamine for sure, and that's one of the reasons I don't like it, because you don't know if they're getting worse or the medicine is working. Milrinone, I don't see that. What is the mortality of a patient you send home on Milrinone? What mortality do you say they have? What's their 6-month mortality? 50%. So we say, they're like, I feel great, doc, should we hold on this medicine? And the reason, and I'm telling you this because you consult heart failure and you're like, I don't understand why you don't just send them home on Milrinone, they feel great. It's because you're essentially sending them home to a place that they don't have a lot of support and they think they're doing well, but they're probably going to die. So really, that's when we're saying, okay, are they candidates for advanced therapies, heart transplants and LVADs, or are they hospice? And really, we should kind of get those things up. So in our heart failure clinic, we're probably following like maybe 5 patients on outpatient inotropes, just because of that situation. Places that don't have advanced therapies end up using inotropes more, but that's just, yeah. All right, let's get to the fun part now. All right, so you've had multiple different lectures, and I've even been here before. So I'd like you guys to tell me a little bit about this slide, and I'm sure you've seen it many times. And just tell me, a few things you know about each, and kind of go from there. Yep. Yeah. What's true shock? You're saying chronic heart failure is not true shock. 0.5 to 1, yep. True. What does it do? And how does it assist? Exactly. So it is our most powerful afterload reducer. And so I like thinking about it like that because you see us hammering them with like nitrite and, the ACE and ARBs and ARNIs and all the afterload reducers. But so this is like a super afterload reducer. And so that's how you get the increased cardiac output. But how does it do those things? How does it increase the coronary perfusion and decrease the afterload? Good. When does it deflate? So, we'll talk about more. Okay, what about the next one? What is it? Impella? Yeah? What does that do? Yep. It's a little tiny microaxial pump. What about the third one? Tandem? Yeah? Where are the cannulas? What's it doing? Yeah, so when in, yeah, how is it getting to the left atrium? Yep, femoral vein through the IVC into the right atrium and then to the left atrium across the septum. So this is a device that's not used as often just because of the additional expertise that's needed to get across the intraatrial septum, but is a very good device. And what can the Tandem provide that the others can't? This one. Yeah, you can hook it to an oxygenator. So when our ECMO numbers are too high, we can make ECMO. All right, so we'll go through the slides pretty quickly because I think most of it is kind of things we've talked about, but indication is cardiogenic shock, preoperative and postoperative support for really any cardiovascular surgery, hemodynamically unstable patients with myocardial infarction, high-risk coronary intervention, bridge to cardiac transplant or LVAD, and particular arrhythmias due to ischemia. We talked about these. I guess we didn't talk about the make sure you have enough filling pressures. So here are some of the how much flow you're getting. And this is most important when you're talking about what is needed. A patient that has chronic end-stage heart failure, giving them the 0.5 to 1 increased cardiac output from the balloon pump, a lot of times is all the body needs because it like doubled it. So, you know, it does, patients don't always need a lot of support. On the other hand, if you acute myocardial infarction or even arrhythmias, cardiac surgery, something that the heart was actually pretty good and then takes a hit, and so the body is used to having normal cardiac output, which is what? At 5 to 8. The body's used to having that, and they have an acute injury. Those are really the times typically that we need to have the devices that have increased support. And then of all these devices, what does VA ECMO do that the others can't? Yeah. What else? Someone said it before with Tandem, but yeah, RV support. All right, one more very important point. Just because you can doesn't mean you should. Talk about some of the complications. So what is happening here? Yep. Didn't keep his feet long. This is just showing by the ruler, you see little clots. And that is a very small clot, but you can see how, you can see how small this pump is. So a clot this size is really blocking this whole pump. If even a piece of this gets pulled in here, the blood comes out of here and goes to the brain, that's still a stroke. So, and still can cause some ischemia even in the lower extremities. So still, even little tiny clots are important. And the anticoagulation for this Impella device is extremely important. There'll be anticoagulation that is coming right through here where the pump is, as well as systemic anticoagulation. And a lot of times, these patients have LV thrombus because their heart is so weak, and so that's something to really look for on echoes before putting these in. All right, so we talked about this. So we see this waveform all the time. What is it? Can someone describe this waveform to me? It's the balloon pump. What's happening? So what's this? LV systole, yep. So what happens with a dicrotic notch? Yep. And then diastole. So here's the balloon pump, normal systole, and the balloon pump is here. Why is it important that the balloon pump is inflating here? Yeah, and so what does that do? We talked about afterload reducing, but if your balloon pump's inflating, so that's really high afterload and bad for the heart. And then really, and so then what are we seeing here? The deflation and that kind of assisted diastole. Yep. So absolute contraindications are aortic regurgitation, just for the same reason why you don't want it inflating before that aortic valve closes. Aortic dissection, it's going up and down in the aorta. Aortic stents, so you don't want to put the balloon up and down when you have stents in the aorta. And then severe peripheral vascular disease. And that's really just because of the vascular access to put these. Balloon pumps can be placed in the axillary artery as well in the femoral artery. We typically do femoral artery, but patients that have to have balloon pumps for extended periods of time, we use axillary more so they can sit up in bed and walk around. And that's really most of the reason for that is waiting for a transplant. So relative contraindications, abdominal aortic aneurysm, sepsis. When you have really significant vasodilation, the balloon pump, you just don't get benefit. So that's the main reason. Bleeding, and then, again, peripheral vascular disease. The one thing about the balloon pump that's different than the others is some institutions, if the balloon pump is 1-to-1, you don't have to be on anticoagulation. We do anticoagulate all our balloon pumps, but if you have to stop anticoagulation and your balloon pump's on 1-to-1, it shouldn't cause a lot of issues or a lot of worry. If, when you're weaning off, you're going to 1-to-2, then that's really important to have the patient systemically anticoagulated. Yeah. Yeah, good question. So the balloon is going up with every heartbeat, yeah. So advantages of the balloon pump, it's obviously widely available, it's easy to insert, it's actually a small French catheter, and we'll talk more, so less risk of distal ischemia in the leg. Disadvantage, it requires your heart to be beating, doesn't give you a lot of increased cardiac output. It relies on the synchronization with the cardiac cycle, and really where this comes into play is in atrial fibrillations or patients that have a lot of PACs or PVCs, it's hard for balloon pumps to really understand when they should be inflating and when they're not. And it's like going fast and then you can't close. So sometimes those are situations where we go to 1-to-2 and the balloon pump actually likes it, or the body likes it a little bit better so that it allows the balloon pump actually to have like kind of a full cycle inflation and deflation. You've probably been by bedside of balloon pumps when it just sounds like it's just like a hammer just going off because they're so tachycardic. So patients don't get a lot of benefit from that. You can have systemic embolization, and that's really because you can get clot on the pump, and then it gets usually distally embolized. Very small risk of aortic dissection. Knock on wood, I've never seen that. Renal ischemia for malposition. So when you're looking at the daily chest X-ray for a person with a balloon pump, what are you looking for? Not an arch. Yeah? Yeah, so what are you looking at for the balloon pump? What can you see on an X-ray? Yeah, there's a little radio-opaque marker right at the top. Where do you want that? Yeah, so on that X-ray where you see that arch, so a couple centimeters below that, or kind of right at the carina, kind of in that area. And they can, depending on patients, they can move quite a bit. One thing is moving them in and out is a really high risk of infection, even though that it is kind of a sheath over it. So just keep that in mind. Every time you move it, you are increasing risk of infection. These are the different Impellas. The number by it is how much flow you can get with it. So 2.5. The CP is 3.5. Impella 5.0. And now there is a 5.5 that is surgically implanted. And then the Impella RP is for right-sided support. So all of these, the curly Q will be in all of them except for the fourth one, but the curly Q pigtail will be in the LV. You see this line right here, that's the level of the aortic valve. Blood is being sucked in through here and then outside of here into the aorta. The Impella RP is the reverse. Essentially, blood is being sucked in here and then in the pulmonary artery here. Well, two things. One is not to rupture the LV because like a nice smooth. Yeah, it's not. This is like really like flimsy. This pigtail part of it. So this is what it is, and this is a picture of the tiny pump within there. So you can imagine, and one of the things I hate about this pump is the hemolysis is just horrible. And you can imagine, you get a little tiny bit of clot, or the heart is so weak that all the blood has to go through this pump. That's the patient's cardiac output because the heart's not pumping, and it just chews up the blood. And so then you're getting hemolysis and renal failure shortly beyond. With the bigger pumps, hemolysis is less, and if you can be on a bigger pump and spinning slower or not as fast, then the hemolysis tends to be a little bit less. But this is, the other part is we do more Impellas, one of the most Impellas in the country. So we're just so heavily Impella here, so we see them all the time. But you probably won't see them as much when you're kind of out and about. But it is, it is a good pump. It has its place. It's very useful in high-risk PCIs where you're putting it in, you're getting quite a bit of support, and then you're taking it out at the end of the procedure. But when it has to be in there for an extended period of time, and when I say extended, I think any time over 72 hours, you're running into problems. In the picture, you can see the placement of it is very important, and this is the mitral valve apparatus, and it can kind of get caught up in there and cause issues. They can move a decent amount. So again, it has its place, but it can be a pain. So contraindications are LV thrombus. We talked about that already. Mechanical aortic valve, for obvious reasons, I think, right? Moderate to severe aortic stenosis, that's mostly because it's hard to get that pump through. And then moderate to severe peripheral arterial disease because it is a bigger French catheter, and so now you're getting into the area of increased lower extremity. Can augment cardiac output much more. It doesn't require the heart to pump. It's just going to spin at whatever speed you put it at, and it's quite widely accessible. Disadvantage, I said the balloon pump is kind of the 7 to 8 French. Now we're getting to 12 to 14 French. It can move. You can get systemic embolization, stroke, infection, hemolysis we talked about. And really, when ischemia, it's talking about peripheral ischemia. So Tandem, you can get good flow. It is a little bit more durable pump than the Impella for up to 14 days. Talked about that the cannula is going across the intra-atrial septum, pulling blood from the left atrium, coming out through the pump, and then back in the femoral artery. So it can increase, and it does a good job of increasing cardiac output, and you can add an oxygenator. A picture. and here with oxygen. Contraindications is severe aortic insufficiency, again, because remember you're pumping just like ECMO, you're pumping that blood back up in the femoral artery. Aortic dissection, and that's mostly because you're, again, putting retrograde flow. Severe peripheral vascular disease, PSD, and inability to tolerate anticoagulation. Yep. Yeah, a lot of times, so yes to when do you use them. It can be a bridge to transplant or out of cardiogenic shock. A lot of times they'll just pull it out, and many times it will close on its own. And then sometimes if it doesn't close on its own, then you treat it kind of an iatrogenic ASD, and then you can put the amplats there to close it. And the advantages can provide 4 to 5 liters, can provide support for longer than an Impella, and again, it does not require stable rhythm. And the disadvantage, talked about it, it requires increased expertise to cross that intra-atrial septum, bigger French cannula, now we're talking about 21 French. And it cannot be implanted during CPR, and that's mostly because you're trying to cross intra-atrial septum, and a lot of times they'll use ultrasound to help guide where they want to go through the intra-atrial septum. The risk of stroke because you're putting blood in the femoral artery because of the bigger French catheter. All right, just a few words on ECMO. We talked a little bit about this, but typical VA ECMO, how does that work for us cannulation-wise? What do we do? Yeah. Pulling blood from the femoral vein, going through the ECMO circuit, which can be pull out the CO2, oxygenate it, and put it back into the femoral artery. When are situations that we would use VA ECMO? Be biventricular failure or even RV failure. Don't use it a ton for straight RV failure, and that's more because there's not a lot we can do to get them off unless they're going to recover, and that's the hardest thing with RV right now, unless we're going to transplant. No, you're just on full support. Again, you guys have had come at this, but bleeding is a big problem. Anticoagulation for VA ECMO is, you can argue, but I think it's, in many ways, it's more important than even VV ECMO because if you get clots in the circuit, you're putting it into the arterial circulation. And so embolization is a problem, whether it's stroke, whether it's distal limb ischemia, whether it's in the other organs. Infection and lower extremity ischemia we talked about. We do put in small catheters that are actually directed down to the leg to try to prevent the ischemia from that side, stroke, and you can have hemolysis. Is this before or after the blood shortage? The technical answer should be kind of 10 to 12 even. Do we do that anymore? We just can't. So to me, it depends on what the patient needs. Because the time that we can just keep pouring blood into them is. North-South syndrome, what is that? And why does that happen? Yeah, so the lungs still aren't working that well, you're still really hypoxic, anything that's coming out is still deoxygenated essentially. Now that native cardiac output is improving. And then how do we evaluate for it? Yeah, so ABG usually in the right radial artery. And not because we really care that much about the arm, but because we care about the brain and really making enough oxygen. How do we treat it? Yeah, if you can. Yeah, if you can. So. So the Impella will actually increase the, yeah. What about increasing the flows on the ECMO, right? So that you have the red blood coming up farther, so that's something we'll try, so that we can kind of go against the LV. And then sometimes central cannulation. So if we put, instead of trying to get blood to go backwards all the way, if we're really putting oxygenated blood up here, centrally cannulated, then that will also. And why do we use Impellas or balloon pumps with ECMO? Because I said you get full support on ECMO. Yeah. So if your heart is really weak, you don't have north-south syndrome, but you have all this blood coming back and making this heart very dilated. And when it's that stretched out and filled with blood, it doesn't have a chance of recovery. We don't use it all the time, but that's when we use it, it's because we feel like we need that afterload reduction to decompress the LV and allow it to recover. All right, we talked about the right a little bit. So when do you do RV support? How do you know? Really, really fast, you can see what the answers are right there and say, slide right down and. So what's the definition of RV failure? Numbers. Yeah. The TAPC is, we can use it depending on the disease process, I feel like. Some people say less than 2.2, some people say 1.6. So yes, that is a way to look at RV. Yeah, you know, the one thing about RV function, like on echo at least, it's just, it just only tells a very small part of the what are some hemodynamic? What RA number do you think is bad? 18? Yeah, it's really. Here's 15, so, yep. Right. What about a ratio from right atrium to wedge? You heard of that before? So if your right atrial pressure is 15 and your wedge is 30, is that RV failure? What happens if your RA is 15 and your wedge is 15? Is that RV failure? So you want that ratio to be less than 0.6. So if you have, and that's the hard thing is you could have an RA pressure of 22, but if the wedge is 40, if you unload the LV, then you're probably going to get the RV to come down. Sense? Happy. What's that? I see a lot of I don't know and I don't care. Happy. Have you ever heard of that? There you go. Yeah? Radial pressure, right? And so really the point of that is one of the equations that's used to say you have an Impella in, and do you need a right-sided support? And so what you can see, what I think is important about this is if you have a PH patient even, for instance, and you have a really high pulse pressure and a low right atrial pressure, that RV is actually hanging in there. If you're able to get pressures of like 85 over 45, that RV, although those pressures are too high and we want to try to treat it, the RV is actually hanging in there. The problem is when you get RV or PA pressures of 30 over 25 and an RA of 18, then that's a problem, and that's an RV that's essentially a conduit. Blood's just flowing through it, and there's really no power behind it. Talked about the right-sided Impella already. So this is kind of the difference in the curve. Blood's being pulled from the IVC into the pulmonary artery. Protect dual, it's the tandem's right-sided. It can be hooked up to an oxygenator. You guys know about the Protect dual, the dual cannula, right? This is a nice paper, just if you ever wanted to go and look at any of this. This is a nice paper from Jack Cardiovascular Interventions that really just goes over each device and what it does to hemodynamics, and as well as a nice algorithm to say, do you need right-sided? Do you need support? How much support do you need? And do you need right-sided? Couple seconds on this. 7 minutes or may less. XVE, the initial, I should have brought this pump. Very large, durable LVAD, first generation, so 2001. And really on that rematch trial on the right, it just showed that although now we look at these numbers, they still look dismal, but we thought it was a big win that with the LVAD, that yellow line, the percent to survival was significantly better. This was how big it was. It had to sit below the diaphragm. It really took out people, smaller people and women for the most part. This was our Heartmate 2 on the right side was the newer generation and was a huge win. It is an axial continuous pump and was way more durable. We had patients that were on this for many, many years, 10 years, 12 years, so much more durable pump. This one, the XVE, had valves that broke down and really get to 2 years was amazing. Heartmate 2, which now is like so last year. And this Heartware, which is no longer in use because of complications, but was a smaller pump and was really a move in the right direction. But really, the Heartmate 3 looks it looks the same a lot, but this is our workhorse and our only LVAD that we are using. So this pump in the LV, the outflow graft to the aorta, driveline still coming out of the body to a controller and to 2 batteries. And really the pulsatile pump, that was the XVE, and the continuous was Heartmate 2, but just we're showing that the survival for patients on these durable VADs has continued to increase. And right now, our survival at 3 years is the same for transplant and LVAD, so it continues to increase. And here you can see the centrifugal is the Heartmate 3, the axial is Heartmate 2, so we continue to improve the survival for these patients. Questions? I think we're following, I think it's like 160 or 170. Right now we're doing about 40 a year. Goal to get more beds. Yeah. Mhm. Yeah, so we see this a lot, and the issue is pH is from his group 2, but because first he's had high pressures on his heart for so long that he had that vasculopathy form. When you look at people that have pulmonary hypertension prior to LVAD, many, many times that pulmonary hypertension does resolve on its own, because if you're unloading the left ventricle for so long, it allows the pulmonary vasculature to kind of remodel, I guess, and the pulmonary pressures go down. But sometimes it doesn't. And why we get crazy about it is we're very, very strict about PVR prior to heart transplant. It has to be less than 2.5. And so, sometimes we'll do like gymnastics and like stand on our head in the ICU to make these numbers go below 2.5. The reason is donors are young, healthy people. They don't have pulmonary hypertension. Their RVs have never seen high pressures. If you take a donor heart and put it into a patient that has had high pulmonary pressures and has pulmonary vasculopathy, then that right ventricle just blows out because it's not used to seeing those high pressures. And so we get like crazy doing things. And before, those patients just weren't candidates for transplant. It was like, too bad, you're living on bad for the rest of your life. But we are trying to do everything we can to try to see if we can reverse them. A lot of times, though, they use sildenafil much more often, but there's a couple of patients that are on more potent pulmonary vasodilators. We continue those after transplant for like a few months, like up to 6 months, and you're able to wean them off, and then they're fine. But it's really getting over that initial, like, new heart that not see those pressures. So you should do CPR. It's going to be alarming. And the main reason is the LVAD doesn't do anything for the RV. If the RV is not pumping, the LV is not getting blood. So you should be doing CPR, but it's mostly to get blood from the right side of the heart to the left side of the heart. There used to be like, don't do it on this pump and do it on this pump. They're dead. Like, try to get them back.
It was really good.
Yeah, thank you.
Makes me want to. I want to do a CIC elective.